normally put it on YouTube. To let everybody know, we are not going to be recording live Q&As with the audience for data privacy reasons. So the recording will only cover the panel talks and also advanced Q&As that I have received from PALB2 carriers that will cover with the panel. So I wanted to kick off with that. So welcome everyone to our 5th annual event for PALB2 carriers and the families. We do have a word UK here because it's led by the UK panel. We're all based here. However, majority of the content is relevant globally, with some variations to the local the medical guidelines, NHS in the UK, for example. So it might vary for you in your own country, so be mindful of that. But we'll give you the perspectives from here, and anything local, please talk to your medical professional on that. Okay, so we've got an hour and a quarter, or a little bit more today. The objectives for today's session, which is 5th one, we've started doing them in 2020. It's self-organized, so I'm very grateful for the time from our panel who take time out of their diary to come and talk to all of us. So today, as always, we get update in research and risk management. I'll introduce the panel shortly. We've got a pancreatic specialist session that we'll got Michael Chapman coming to join us a bit later on, and then we've got Q&As. And I found from the previous experience that there's actually quite a lot of Q&As being asked. Please do use the chat room here, and also ask live questions later on in the session. So a bit of a timing, who is speaking when. So after my introductions, I'll hand over to Marc and Anju to talk about the latest developments. Then we'll cover the Q&As because Mike is running slightly late from his clinic, and he will join us about 5:30, maybe nearly 6 o'clock. So we'll take some time to answer what you've sent to us in advance. Mike will talk about pancreatic research, Europac study surveillance in the UK, and then we open to Q&As. Right, let me introduce the panel today. I'll start with myself. Yulia Baynham, I'm a chair and facilitator of the panel. I'm a PALB2 carrier. I had my diagnosis in 2019. I'm a financial services consultant, but outside of it, I involved quite a lot in various programs led by University of Cambridge, Cancer Research UK, international programs, and also I spent 5 years as a vice chair of the local cancer charity based in West Sussex in the UK. Mike, who will join us later, I mentioned he's a consultant gastroenterologist from the University College Hospital in London. Marc, our top guru in PALB2 and our key speaker today. Marc is Professor of Medical Genetics at the University of Cambridge, leads multiple studies in PALB2 and a top global specialist. And Anju Kulkarni is our consultant clinical geneticist and leads the cancer genetics service at the Guy's and St. Thomas's Hospital. Vishaka, who is not on the call today, but I'd like to introduce her. She's a standing member of our panel. Between Marc, myself, Anju, and Vishaka, we cover the sessions on an annual basis. And I wanted to acknowledge her contribution to the panel and all Q&A sessions has been helping us with. Okay, so some resources. I just wanted to point you all to previous sessions, particularly the first and second one, covering quite a bit about what PALB2 gene is and specific details around that. All of the sessions, all the 4, you can find on YouTube channel and also on the PALB2 interest group website, which is listed down there. So if you want to go back to previous sessions and get some more learning about the gene and what the impacts are, they could be found. We also published a booklet a few years back. We'll update it shortly. That gives you quite a lot of information about PALB2, i.e. everything you need to know in one pack. So please refer to that. And some ground rules, as I mentioned, about the Q&As and how we're going to run this. We'll provide you with some guidance, and but specific information about your personal case and your medical history, we won't be able to cover today in detail because that needs to be discussed with your medical profession. So please don't treat it as a medical appointment, but we will welcome all the questions and see how we can answer them for you. So thank you so much for everybody and your participation in this event. Okay, so I'm going to now hand over to Marc for the intro and for him to cover what's new in the research and developments in PALB2. Thanks, Marc. Over to you.
Thank you very much, Yulia, for your excellent introduction, and thank you also for organising everything actually and keeping us all in check and actually making this happen. So we're very appreciative of you. And so I'm going to kick off just talking a bit about new things that have happened in PALB2 over the last 12 months or so, since the last time we did one of these sessions. And can you have the next slide, please, Yulia? Great. Okay, so I have showed this slide before, and just next again, please. So this gives you an idea of how common PALB2 pathogenic variants, so PALB2 mutations, are in the general population and also in the population with breast cancer. So the top 3 genes really in hereditary breast cancer are BRCA1, BRCA2, and then PALB2. And you can see that on the third column along, it tells you about the frequency in the population. So you can see that 1 in 1,000 people carry a pathogenic variant or mutation in BRCA1, about 1 in 400 carry it in BRCA2, and about 1 in 750 carry it in PALB2. So in fact, there are more PALB2 carriers than there are BRCA1 carriers. Yet BRCA1 and BRCA2 are much better known about. And this is really a legacy of the timeline of when these were discovered, because the first 2 genes, BRCA1 and BRCA2, were first found in the mid-90s, and testing started pretty much straight away. So we've got nearly 30 years of experience of testing those genes. PALB2 was found in 2007, and then it took about another 10 years or so before it got tested routinely. So we haven't even got 10 years worth of testing experience with this gene, and that's why it's very much the number 3 here at this point. And I think the name doesn't help as well. I think really we should have called it BRCA3, and I think people would have a better understanding of it. It's not easy to change the official name of a gene, but maybe unofficially, we should start thinking about calling it BRCA3. And you can see, so these 3 genes between them account for about 2.5% of all breast cancers, and so it's about 1 in 40 breast cancers roughly. And you can see that for BRCA1, about 1% of all breast cancers, any breast cancer, is caused by BRCA1, and the PALB2 is about 0.5% essentially. So that's not much, but we are talking about all breast cancers. And if you start looking at younger breast cancers, so those that occur in women under 50, then those proportions go up quite considerably. Can I have the next slide, please, Yulia? A question that we get asked about often is the type of breast cancers that are linked to PALB2. And this is a table that shows you a whole range of different genes, and the particular breast type of cancer that people are interested in is something called triple negative breast cancer, and that's because it often involves a different type of treatment management compared to the hormone positive breast cancers. And you can see on this slide that if you look at the top row there with the BRCA1, almost the majority of BRCA1 breast cancers are triple negative. So it's much more common to have a triple negative breast cancer if you're a BRCA1 carrier. Then if you go right down to the bottom where it says none, so that's those are people who don't carry any mutations. You can see that on average, only about 16% of all breast cancers are triple negative. So you can see how different BRCA1 is. And interestingly, the BRCA2 gene and the PALB2 gene have a very similar proportion of triple negative breast cancers. So it's slightly higher than general population, but nowhere near what it is for BRCA1. So some women who have breast cancer will have a triple negative type, slightly more common in PALB2, but the vast majority will still have hormone positive type breast cancers.
Marc, how common is to have multiple gene alterations?
What, in more than one gene?
Yes.
Not very common. It does happen. So you could have, you see it somewhat in the Jewish population because some of these are quite common in the, because some of these genes,
I want him to
some
die.
of these are quite common in.
I want him to die.
some of these are quite common in, so there are founder mutations in the Jewish population for BRCA1, BRCA2. So you do get that happening, but actually it doesn't seem to increase the risk at all, because these genes are all working in the same pathway. So if one of them is not working, that's already causing a problem. And then if you've got a second one not working, that doesn't really seem to add to that problem because the pathway is already not working properly. So the short answer is yes, we see it sometimes, but it doesn't really make much difference as far as we can tell. Could I have the next slide? So I think this is a new study that's come out, and there's a lot of data on here, but I really just want you to focus on PALB2. And the other question we get asked quite a lot is, does having if you've got a mutation in this gene, does it affect the prognosis of your breast cancer? And this is a good study done by some colleagues in Stanford in the US, and they looked at a very large public data set and of nearly 80,000 patients in America. And what they were trying to do was look at is there any difference in prognosis if you've got a PALB2 gene mutation compared to if you don't? And if you look at these two graphs, there's a straight line that goes down the middle, which basically that's where you sit if there's no difference in prognosis. And you can see that the PALB2 lines for both of them, the dots are slightly on one side or the other side of this straight line going down the middle, but there are lines going through those dots and they cross the straight line, and that means that as far as we know at this point there isn't any difference in prognosis. So this is quite a good, this is a statistical way of trying to answer this question. It's not perfect, but the advantage of it is that it is based on a very large number of patients, so it is giving us some idea. Maybe one criticism is that the actual number of PALB2 carriers, even though these are large data sets, the number of PALB2 carriers is relatively small. But still, I think that's quite encouraging, actually, that there doesn't seem to be a major difference in prognosis if you carry PALB2 compared to not carry any gene. Next slide. Okay, so the other thing I was talking to you about was how we improve risk estimation. So now we're going to talk about unaffected women who carry the gene, and they want to know about their breast cancer risk. And for this, we use a program called CanRisk, which was developed by colleagues here in Cambridge. And this here, I've just shown you on the left-hand side, there's a family tree, a very simple one, with a 40-year-old woman who's got a mutation in PALB2, and neither her father nor her mother are affected with cancer. Presumably she inherited this from one of her parents. We don't know which one. Doesn't really matter for the purpose of this. If we put that family tree into our risk estimation program, you get the graph on the right-hand side, and that shows you that her lifetime risk is probably going to be about just under 50%, basically, based on just that family history and her being a carrier. But can we do better than that? Because there's more factors that we can include in that risk estimation. Can I have the next slide, please? So, one of the things about risk is that there's a continuum. So we know that there are some of these genes like PALB2, BRCA1, BRCA2, and they cause a very strong, they're a very strong cause of breast cancer risk. So you've got one of those genes, you're going to be a bit of an outlier. But for the rest of the general population, there'll be a whole range of different risk estimates and it'll be fairly random. It'll be by factors such as other genetic modifiers, weak genetic modifiers. And if you think about, height, there's a whole range of men and women some are very tall, some are very short, most are in the middle somewhere. And breast cancer risk is a bit like that as well. And the same genetic factors that influence height, which is like, there isn't one gene that influences height. There are hundreds or even thousands of little modifiers that influence height. We see the same thing in breast cancer risk. Next slide, please. So another way of looking at it is if you take a load of individuals and most people for height, using that as an advantage, or for breast cancer, will be around the middle. There will be around the average. But then as this curve will spread out and out and out, and on one side of the curve, on the left side, you're going to get more people who are at much lower risk because they've got lots of protective genetic factors, and then on the other side, they're going to be at higher risk because they've got genetic factors that are increasing their risk of breast cancer. So this is above and beyond the genes themselves, and so because the genes don't work in isolation, and these other factors, which we call polygenic scores or polygenic risk, they're also influencing the genes themselves. So how can we capitalize on that to improve the risk estimation? Next slide, please. So coming back to this family where I showed you the average risk for a PALB2 carrier. Next slide. So if we then, as well as just doing the genetic testing, if we measured all the other genetic modifiers and gave a genetic score through the breast cancer polygenic score, and let's say this lady had a particularly high one, where in fact nearly only 6% of the population would have a higher score than her, and the vast majority of the population would have a lower score. So she sits right over here. Then you can see that her risk has gone up from just under 50% to over 60%, nearing 70. So that's the effect that these sorts of other modifiers can have on individuals. Next slide. And conversely, if we did the other way, if she actually had a lot of protective genetic factors, we put it down the other side, and you can see how that risk goes down to nearly below 30%. And I think this is one of the reasons why there are some women who get breast cancer who've got the gene, and there are other women who don't get it, because these modifiers, they don't run true through the family. They're sort of more diffuse and they're spread out, and every sisters or siblings will have different combinations of these other modifiers. So I think this explains why some of the difference in why some women are diagnosed and others aren't. And this has also been very successfully used in prostate cancer as well. So there are some cancers where this sort of concept has been very well characterized. We're not currently offering this in routine clinical practice, but we have just done some studies looking at this in more detail to see how it might work in clinical practice. And we're also working with some Australians about this. And I imagine some papers will come out about this next year. Next page. So, but even then, what we're currently doing is based on fairly simple premises, based on small amounts of data. And what we really want to do is actually have much larger data sets to work on, because the data really gives us the power to refine this more accurately. And this is the subject of a new study. I'm not sure you can see that too well, but it's called Beyond BRCA1/2, Enhancing Risk Prediction for Breast and Ovarian Cancer Gene Position. So the first picture there, the cartoon, that's what ChatGPT thinks we look like. And then I've also put the photos in of what we look like in reality. So I'll let you decide which one you prefer. But in essence, this is an international collaboration. So we have people here particularly between the UK and Australia. So we've got some colleagues in Australia there on the right-hand side. Next slide. Yeah, so we've got this. This has now been funded by CRUK provisionally, and we'll hopefully hear more about that shortly. But this is an international study, and we've got this new group called Simba Plus together, and this is going to involve collaborators from nearly 40 different countries, essentially. And you can see we asked them in 2024 how many PALB2 carriers does each centre have, and we came up with a total of over 2,000 females and over 300 males. And we're also we're not just looking at PALB2, we're looking at some of the other non-BRCA genes as well. So you can, some of you may have heard of some of the other genes, but today we're focusing on PALB2. So you can see that is quite a decent number. Now the next step is the challenge. The challenge is actually coming up with all the legalistic and collaborative agreements that we need to do between all the different centres to allow us to share the DNA samples and the data. And that's going to be a lot of work, and then the science behind it will be quite trivial in comparison. So we are going to spend quite a lot of time dealing with administrators and lawyers for the next six to 12 months to get all this together, and then we can do the science behind it, and hopefully we'll have some, doing this sort of large scale work globally, internationally, gives us the power to ever more refine the risks of cancer for carriers. So that is the real goal of this. So this is, luckily or thankfully, we've just been funded by CRUK to do this work, and it will start in earnest in June next year. Next slide, please. So, and how can you help? So we have the PALB2 interest group, which we have sort of expanded into looking at these other genes as well, because it does give us more weight. internationally, and also to get funding for the sort of projects that I've just spoken about. We have our website, and if there's one thing I'd like you to do today, if you could do me a favor, and that's click on the website and just try it out. And the reason is that it was down for nearly 12 months because we had a cyber attack. And it used to be, whenever you Google PALB2, it used to be the first thing that came up. But now, sadly, it's kind of slipped down to about page 3. So I think I need lots of people to click on it and bring it back up to give it the profile that it deserves. We've also given it a bit of a revamp while it was down. We thought we'd use it as an opportunity. And if you have any suggestions in terms of what you'd like to see on that, then please do let us know. We have a generic email address here for PALB2 queries. And then there's also the Embrace study, which is, many of you may already be part of this, but this is how we collect data on PALB2 carriers to try and answer these questions that help us then feed back, the best advice we can to carriers. So it's a virtuous circle. We obtain, you give us permission to use your data and your DNA samples. We use it in large studies to come up with better risk estimates and look at all sorts of other aspects of this condition. And that's a national study run through Cambridge. And what I spoke before about was an international study. So the international study is on the back of what we're doing here in the UK. So please do help if you're able to. And I'll finish there. Thank you very much.
Thanks very much, Mark. And I've received quite a few emails or asks in the group about who is Marc in my country, and Marc's been very helpful to connect and give the best PALB2 specialists names for those who like to find them.
We could definitely help with that. For most countries, we know someone who's interested in PALB2.
Very helpful, thank you. Okay, so I'm gonna leave the questions on here into the open Q&A. So if you would have any question on what Marc just said, please post them in the chat. I know Mike has joined us. Mike, are you here?
I'm here. Can you hear me?
Excellent. Yeah, thank you so much. I did the introduction for yourself earlier, and thanks for joining. And yeah, we're super excited to have pancreas side of things covered this time. There's a lot of questions always about pancreatic cancer risks. What are they for PALB2? So if you can demystify for us what people need to be doing, what's the UK view? There will be a number of international PALB2 carriers on this course. So it might be differ in every country what the screening is. But yeah, I look forward to hearing from you what's happening in the UK and what your advice is.
Okay, so thanks for the introduction. Couple of things. Well, I'm on 2 screens because my clinic computer doesn't have a mic or a video, so I'm on my iPhone as well, which is the odd angle. Anyway, and I'm a gastroenterologist, so I'm a gastroenterologist with a particular interest in liver and pancreas disease. I'm not an oncologist and I'm not a geneticist. So certainly in the UK, and I think most countries, people with pancreatic cancer initially present to people like myself, and we work people up with suspicion of pancreas cancer before handing them over to the oncologist. So most people with pancreas cancer don't have a recognized genetic mutation as a risk factor for their pancreas cancer. They're thought to be sporadic cancers, but some people do. And this is where MyLink comes in, and you've searched out the questions around the EuroPac study. And people who have a genetic mutation that puts you at some risk of pancreas cancer can be offered screening as part of a trial in the UK, because there's not really known to be any benefit of screening to date. And that's the EuroPac study. So if we just talk about a little bit of the background. Actually, sorry, you've got the slides, haven't you? If you can move to the next slide. So the risk of pancreas cancer in people carrying the PALB2 mutation is not very well defined. And the best information comes from 2 ways. One is to take out a series of people who've had pancreas cancer. So this study, for example, of 3,000 odd people who had pancreas cancer, and sequence them to see how many of these people have got PALB2 mutations, then approximately 5% of them did. Okay, and if you take it the other way around, about 3% of people in other studies would probably have PALB2 mutations. Now, if you got PALB2, what's your risk of getting pancreas cancer compared to the average person in the population? then that's probably just over doubled. So it's not one of the commonest cancers, but it's not a rare cancer. And I think the relevance of pancreas cancer and screening compared to other cancers is that it does tend to present late. There are very few early symptoms, and outcomes of pancreas cancer are very poor, which is why the question of screening comes up. Now, some cancers like bowel cancer screenings are really, really good and effective program in terms of improving outcomes and picking up early disease. But for lots of other cancers, and I think the thing that's been contentious this week in the news has been prostate cancer, of course, has hit the headlines. There's a lot of debate about the pros and cons of screening, and I think the pancreas comes into that group. It is likely that people with different variations of the PALB2 mutation have different risks, but we don't know the answer to that in terms of pancreas cancer, as far as I'm aware. And the lifetime risk of getting pancreas cancer is thought to be about 2 to 5%. Next slide. So EuroPac is a study that's coordinated by Liverpool. They are the people who designed the study and run the study. And there's a few centres around the UK, which you'll see on a map in a moment. And we are the London centre in the UK, and we see a lot of people from Norfolk down to the south coast. So half of the EU families or patients or people screened with a genetic risk of pancreas cancer and a family history of pancreas cancer come to our unit in the UK. Hence the fact, our interest in this. Next. So you can take part if you've got one of two things. You either have to have 2 first-degree family members with pancreas cancer, and some of our families have got 5 members of the family with pancreas cancer, or you have at least one family member, close family member, and a recognized genetic mutation, and they're on the list coming up in a moment. Next slide. So the units in the UK that are currently screening are in Bristol, Liverpool. There's a couple up north, but and one in Wales, and down in Bournemouth as well. But currently, very few of those centres are seeing many patients. It's mostly in Liverpool and London. Okay, and we're trying to expand the screening elsewhere. And the other thing that's been talked about, which we'll come on to a little bit, is whether the NHS will pick it up more generally. Okay, next. So the surveillance protocol is that you get seen by one of the team, talk through the point of screening, the pros and cons, because it does introduce hassle, anxiety around having tests which are not without their own risks in terms of contrast and CT radiation in people who have mutations that put you at risk of radiation damage, for example. And then there's also the baseline blood tests, and then after that we do an annual endoscopic ultrasound. That's what EUS stands for, and that involves putting quite a big endoscope. It's not like a standard gastroscope that we use for most endoscopy. It's quite a big endoscope that has an ultrasound probe built into it, and that goes down the back of the throat into the stomach, and then we can see the pancreas quite closely through the back wall of the stomach because they sit next to each other. The problem with that, it is an invasive test, and unlike a normal endoscopy, it does have some risk of causing damage because it's a big scope, so we can cause tears and bleeds by doing the procedure. Risk of that's only about a 1 in 1,000, but that's not a 0 risk in somebody who's well and having screening, which is relevant. So if you're doing an endoscopy and to biopsy a pancreas because you've identified a lump, that sort of risk is almost not relevant, but it is relevant if you're a completely well individual, and it is an unpleasant intervention. So most people have sedation to the point of being drowsy, but still can be an unpleasant day. And it's a day out of your life where you can't do anything afterwards and so on. So there's significant hassle involved in screening. The annual blood tests are probably not very useful for screening of pancreas cancer. One of the questions that's coming up in the studies is whether a slowly increasing trend in your blood sugar or your HbA1c, which is another way of measuring blood sugars, or your CA19-9, which is a vague tumor marker for pancreas cancer going up, even if it's not quite got out to the normal range, would be an early way of indicating disease with very easy non-invasive tests. That hasn't yet been shown, but that's one of the questions that's coming up. And that sort of comes into a little bit around the general NHS process of people who have vague abdominal symptoms, unexplained new onset type 2 diabetes, and weight loss will get screened for pancreas cancer with imaging as routine practice now, even if there's nothing else that presents like pancreas cancer, like onset of jaundice and things. Once you've had your baseline screening, we then follow up with bloods, an endoscopic ultrasound every year, and an MRI pancreas to try and reduce the CT radiation every 3 years. Next slide. I'm not aware of many formal programs in many other countries. The US has a program, and this CAPS consortium, which is an interesting group of people who've put together a question of screening, and they've presented some data in terms of screening, probably reducing your improving your outcome if caught early. Now, there's a lot of debate about whether that's just finding the disease earlier, and so you're earlier on the graph of deterioration, or whether it truly does increase your improve your outcome, and that's still yet to be proven, I think. But probably early detection improves outcome. Now, the sad thing about pancreas cancer is that the blunt reality is that it doesn't have the prognosis and good outcomes that have been seen with modern oncologic therapies for lots of other cancers. And so even when you have what we think may be a curative resection of a small, early, incidentally found or screen found cancer, outcomes tend to be a lot worse than you might imagine with what was, a stage 1 disease, for example, because it tends to spread early in ways that we just don't see or can see on imaging. Next. So this is just to point out that in the American systems, I think the next slide shows the same, that PALB2 is considered one of the gene mutations that should put you into at least the question of whether you should get screened for pancreas cancer, but you need to have a family history as well. Next. That's the same thing. So that's the American Society of Gastroenterology guidelines. Next. And in the UK, the NICE guidelines for pancreas cancer, these are not evidence-based, but are opinion-based, even though the NICE guidelines are supposed to be firmly evidence-based, say that we should offer surveillance for pancreas cancer in people with a hereditary pancreatitis, which is a different group of people, or people with one of these recognized gene mutations, which includes PALB2, and one or more first-degree relative with pancreas cancer, which is essentially the same as the EuroPac study. And that's because these guidelines were mostly written by the EuroPac team in Liverpool. Okay, next. So you might say, a bit like the debate that's come up with prostate cancer this week, why don't we just screen everybody for all of these difficult to treat diseases, so we pick them up early? And the NHS measures something called QALY. So they argue a case for there has to be a reasonable cost to benefit ratio of an intervention. And currently there's not enough evidence of benefit to justify screening widely across the population of pancreas cancer, unlike the benefit of screening of bowel cancer, where that's proven to be of benefit. The other problem in the pancreas is a couple of things. First of all, it's really quite common to have incidental findings on tests. And I think one of the questions I've since read since I put this in was about IPMNs. So that's a very common incidental cystic lesion in the pancreas, which we see in about, that's debated amazingly when it's so common, but probably up to 10% of the population can have these little cysts in the pancreas, which are difficult to define, but the majority of them are assumed to be mucin-secreting cysts, which are called IPMNs, and they are said to have an increased risk of developing pancreas cancer, which is not related to genetic mutations like PALB2. These are sporadic things, which the cause of which we don't understand, but it's not related to known mutations. So the risk of getting cancer in those incidental findings is pretty low, and currently we are screening thousands and thousands of people who have these incidental findings of cysts in the pancreas, and the number of people coming back with disease is very low. Most people who present with disease related to these things present with their cancers not during a follow-up time, so that current guidelines are being discussed in Europe and the UK about reining back some of the screening so that we're screening less frequently and only for a short period before stopping screening. If the cyst is very large, then we would start to get worried about it, or if it has wall thickening or the tube drainage, the pancreatic ducts of the pancreas changes, then we would worry about it. But if we find incidental cysts up to sort of 1.5 centimeters or so, we generally consider them very low risk of getting cancer, and they're not linked to these genetic mutations. Other tests require contrast, MRI contrast, X-ray radiation, so you can't see the pancreas very well with a standard ultrasound scan that you use, for example, for gallbladders and things really effectively. It's not very effective at looking at the pancreas. So it does involve tests with risks and medications and coming in and cost. And then if we do find things in the pancreas is one of those organs that's really difficult to reach. You can't biopsy the pancreas through the skin very easily. We used to historically, but that's almost never done now. You can't really, but it's at the back of the abdomen, right in front of your spine. So we used to sometimes get through the back of the body as well to get into the pancreas. Now biopsies are taken on by endoscopic approach with that procedure we talked about earlier, the endoscopic ultrasound, where you put a camera down the back of the mouth into the stomach, and then you can use the ultrasound probe built into the endoscope and the access port through the endoscope to put a biopsy needle through the wall of the stomach into a lesion that you can identify on endoscopic ultrasound. Now that it is an invasive test, it's a relatively low risk test for biopsies, but still up to 5% of people who have biopsies might get complications like bleeding or pancreatitis, which can be a problem. And so accessing the pancreas, if we find things, is difficult, and it can be difficult to define the different pancreas lesions, and hence other tests sometimes are better first, like different types of MRI scans, different types of PET scans, which can define other things we commonly see in the pancreas, like neuroendocrine tumors, which are managed quite differently to pancreas cancers. So, and the big issue with all screening programs is you have to prove a benefit of screening before you can put it out to the broader community. And that's where even for pancreatic cancer, which is a bit easier to get to than the pancreas and has effective treatments, they've not shown a benefit. And so we don't have those easy access and beneficial treatments in the same way as some other cancers for the pancreas, hence the fact screening's not been moved more broadly, certainly to date. Next. Oh, here's the pancreatic cystic question. So they are common. I think if you have had a scan because you've got risk and people find a cyst, then clearly, it's human nature that you start worrying about them and saying, well, have I got pancreas cancer? The answer is almost certainly no. And they will probably get followed up, but don't worry about them because they're not the same thing as solid lesions. Next. Okay, that's it. I think I'm going to end there and open up to questions if that's the case.
Yeah, thanks very much, Mike. We'll do questions in the Q&As. I just wanted to ask you, for those who could be screened, from what age is that going to be?
Oh, yeah, good question. So the general rule of thumb, in fact, for lots of screening as well, is for this program, it's 40. Sometimes younger, but the general rule of thumb is 10 years younger than the youngest affected family member. So hence the fact, if you've got a brother who's had pancreas cancer at 45 and there's a strong family link and a genetic mutation, we would then potentially take people on from 35.
Thank you very much for that. Okay, we'll start off with the Q&A sent in advance. We'll also check the chat, and then, yeah, we'll open to the audience. Hopefully, we have answered some of the questions already. So we've got about 25 questions I've received through the PALB2 Facebook group. They're quite usual. We get them from year on year. Generic research, links to other cancers, hormones, insurance access, and then children, screening children and risks for them. Okay, so I'm going to start with the first set. Any updates on preventative treatments and new discoveries, Marc?
I just wanted, is Mike around? Are you around, Mike, long enough to? Because there are some specific pancreas ones, so I don't know if we should do those first.
Yeah, no, I'm a go. I finished my clinic.
You're fine. Okay, good, fine. Yeah. So updates in preventive treatment. Well, we're looking at. I mean, there are already preventive drugs available. So tamoxifen and aromatase inhibitors are preventive drugs for breast cancer, and they particularly prevent hormone-positive breast cancer. So, though certainly for women who who are not keen on risk-reducing mastectomy, preventive mastectomy, then there are those options. As with any drugs, there are side effects to them, although they're generally quite well tolerated. So those are already available, and that is a discussion with your team, with your local team, if you're, if you actually are eligible for those. But that's certainly a possibility. We're also just doing some preliminary work looking at another class of drug called PARP inhibitors, which are currently used in the treatment of cancer, whether or not they could be used as a preventative drug. That is still quite a long way down the road. So I think that's going to be like a 10-year project, basically, to see if that's going to come to fruition. So we're just currently putting together some thoughts about how that might work. So I think those are really the main areas in breast. And in ovarian, the best preventative drug is the contraceptive pill, which has a very, there's very clear evidence that has a long-standing protective effect against ovarian cancer, particularly if you take it at a younger age.
When you said PARP inhibitors, olaparib is one of those?
Exactly, yes. That's the common name for it. But that's a long way off still, because there's a lot of hurdles that we need to overcome before we start giving that in prevention. But we're thinking about it. We're at the thinking stage of it and how it might work.
Hey, what's on the pancreatic side, Mike? Anything there?
None that we're using. No, nothing. So if you take out patients who have chronic pancreatitis, other things like genetic pancreatitis that do put you at increased risk of pancreas cancer compared to average, there's no guidance to screen people with chronic pancreatitis, and there's no drug treatment that we know will reduce your risk.
Mike, what about risk factors like weight? So if you lose weight, does that help?
Well, being overweight and smoking are risk factors for pancreas cancer, yes. But I think that's true of most cancers. I don't think that's specific to pancreas.
Then you can ask about Ozempic then. It's a usual question.
Ozempic's an interesting one. Yeah,
weight. It helps to prevent cancer here from my oncologist, potentially.
So Ozempic, presents to us in other ways because people sometimes get pancreatitis on Ozempic for various reasons. So, yeah, we're seeing a different group, and I have seen a couple of people who have assumed to have had pancreatitis from Ozempic use, but it turns out that what's hidden in their pancreatitis is a cancer, and it's the cancer that's caused the pancreatitis, probably. It's one of the causes of pancreatitis.
Okay, the next question. Thank you, Mike and Marc. Gene therapy and gene repair.
So I think that's still quite a long way off, but it is unpredictable. So there has been a lot of progress being made in the last few years with CRISPR technology. Gene therapy has actually been around since the 80s, and for many years was just seen as a dead end and not going anywhere. And it has taken off somewhat with those new concepts. It's become easier to do, but I think the issue there still is how we actually deliver it to the relevant place, and whether or not you need to do, and when you would want to do that as well. So how can you use it to prevent breast cancer risk? So I'd say that is within our lifetime. Yeah, maybe. I mean, but it's a bit of an unknown, I think, at this point. And it's one of those things that if it's going to be incrementally, if there's going to be incremental progress, it will take a long time. But you, at the moment, you can't tell. Sometimes there are these leaps and bounds with research where things accelerate quickly.
Okay, the third question on
yeah,
improving
sharing of testing companies.
Uh-huh.
So some companies are quite good at sharing, and certainly if we think about the UK, the NHS laboratories that do this testing are very good at sharing, and there is actually there's a clear network where we get email alerts from clinical scientists. So someone in Manchester, has found a variant that they're not sure about, they can put an alert out on this network that we have, and other scientists in NHS labs can then give their own thoughts and opinions on it. So that works very well through the NHS. Again, initially set up through Cancer Research UK, and now being run pretty much by through the NHS itself. And some companies are quite good at sharing. So there are, if we talk about US companies, there's some very good ones like Ambry and Invitae and Fulgent, and they seem to share most of their data. Other companies like Myriad are less good at sharing. And these are all shared then anonymously. Everything is done anonymously, so you should be aware of that. And there's a US website called ClinGen, I think it's called, where these variants are all listed, and you can look at them up and you can see how different companies might interpret them in different ways. So there's different sources of looking at this data, and generally it's pretty good.
We've seen Share My Variant being advertised quite
Yeah,
a bit.
that's a patient-driven, also another way of doing it, basically. Yeah.
And when it collects the data or connects the variants or shows how many people have particular variant, how does it impact the treatment or outlook for cancer? Does that matter? Why does it matter?
Yeah, so I think this is important. The VUS is important because most of those are probably not going to be true mutations. Most of them are going to be rare normal variations. So you wouldn't want to treat someone based on these, so then it's coming down to a woman who's, got a breast cancer. You find a VUS, what's the risk of getting another breast cancer? If it's a normal variant, that risk is not going to be, any higher than anyone else. So that's where these decisions become important.
Hey, what proteins and pathways are disrupted in PALB2, and if there are any environmental vulnerabilities?
So the main pathway is to do with actually our DNA is being mutated all the time, and some of that is just random mutation that occurs, as we live longer, and that's why most cancers occur at an older age. It's just you've been around long enough for one of these mutations to actually develop into a cancer, and the body is continually repairing all these mutations, and that is the DNA pathway that the PALB2 works in. So if the PALB2 is not working properly, the rate of repair is less good, the repair rate is less good, and you get more mutations that creep in, and you get cancers that develop. What we don't understand is why these only really occur for certain organ sites like the breast and the ovary and the pancreas. Why isn't this more universal? Because this is a very fundamental pathway, and that's still something that we don't understand very well for many of these genes and many pathways. It's not just PALB2 specific, it's very general.
That's a good specific breast cancer questions. Yeah, how does a PALB2 mutation make our breast cancer different to somebody without the gene?
Thanks, Yulia. I suppose this was answered in Marc's talk, wasn't it, to a degree, the different sort of histological subtypes of breast cancer, and the fact that triple negative breast cancers aren't as common with PALB2 as they are for BRCA1, for example. So I think that might have been answered, but was there any other aspects you think we need to cover?
I think it's fine, but there are some questions whether higher ER positivity also is driven by genetic mutation. I think similar to triple negative.
I mean, most sporadic breast cancers are estrogen sensitive. So I think when it comes to, as Marc mentioned, those studies, the PALB2 and BRCA2, they do tend to, and even ATM-CHEK2, they tend to mimic those sort of sporadic type cancers in that they tend to be estrogen sensitive more commonly. And it's really BRCA1 RAD51C, RAD51D that tend to be perhaps associated more with triple negative breast cancers.
Does PALB2 affect the risk of recurrence?
So what impacts recurrence risk in breast cancer is going to be the stage at which it was diagnosed, the histological subtype, the type of treatment that you had, how responsive the cancer was to that treatment, how effective the surgery was. Those are the kinds of things that determine recurrence risk. I'm not aware that PALB2 mutations per se are going to worsen or increase risk of recurrence. And as Marc pointed out, that relatively new study looking at prognosis seems to suggest that having a PALB2 mutation doesn't make the prognosis of breast cancer worse. So really recurrence risk is always going to be determined by stage, histology, those kind of pathological factors, and the treatment plan for individual women. Also whether they have other comorbidities, that perhaps other medical issues that make it more difficult for them to complete chemotherapy, for example, or to have radiotherapy. Those are the kind of factors that will influence recurrence risk.
What about I was going to just add to that, developing cancer in the breast in addition to recurrence. What are the chances for PALB2?
So we do know that for PALB2 there is a higher contralateral breast cancer risk than a woman who doesn't carry a PALB2 mutation. It's again influenced by lots of different factors. So in the same way that your initial breast cancer risk is going to be influenced by things like polygenic risk, which Marc talked about, things like environmental risk factors, hormonal risk factors, it's same will hold true for the contralateral breast cancer risk. And I think in terms of the figures, it's we kind of quote around a 2%, 1 to 2% risk per year of developing a contralateral breast cancer. Having said that, that's going to be influenced by many other factors, and it will also be influenced by the treatment that you maybe have had for previous cancers as well. And so I don't think you can necessarily pinpoint a specific risk. Using tools like CanRisk can help in terms of determining contralateral breast cancer risk, and that's often what we do use, the tool that we do use to help women make decisions around risk reducing mastectomy for the unaffected breast when they're found to carry a PALB2 mutation. Marc, did you want to add anything? I'm conscious it says Anju / Marc.
No, I think that's great. That's a good summary, actually. Good summary. Yeah. I mean, it could be that the treatment for, as you said, the treatment for the current breast cancer may also prevent the next breast cancer. So drugs like tamoxifen and aromatase inhibitors not only have a treating effect, but have a preventative effect as well.
Yeah.
I think we answered. Thank you so much. I think we answered question 7. Opinion on enhanced screening versus preventative surgery.
Oh, it's a difficult question, and the one that obviously we spend time counselling patients around that decision between screening versus surgery, and there are many different things that are going to influence someone's decision. I think it comes back again to those long-term outcomes, and I'm still not aware that we have clear data to suggest a survival benefit from having risk-reducing mastectomies for PALB2 carriers. So even for BRCA1 and BRCA2, the data is contentious to a degree as to whether surgery will result in better long-term outcomes. And we know that surgery would, ultimately then comes down to that decision around early detection versus prevention of a cancer. It's going to be influenced by people's familial experiences, their personal experiences of breast cancer or ovarian cancer, what their personal history is, and their own perception of risk as well. And all of those things are what are the aspects that we go through with patients when we're talking about these options. So I don't think it's a one size fits all at all. And I don't think we have clear data to say that one is better than the other for PALB2 carriers.
Okay, we'll move to, thank you, Anju. We'll move to ovarian cancer questions. What about the prevention and which doctor?
Okay, so ovarian cancer screening has been in the news quite a bit recently, and some of you may have heard about The studies that have been looking at ROCA, which is the risk of ovarian cancer algorithm, as a sort of screening tool to look at women who have a high risk of ovarian cancer and whom perhaps want to delay having risk-reducing ovarian surgery or still would like to have children, and so they want to be considering screening options. The ROCA algorithm has been shown to perhaps shift the stage at which ovarian cancer is diagnosed. But again, I still don't think we have long-term data to show that that stage shift will result in better long-term outcomes and better survival. So at the moment, surgery is still what we would recommend from a certain age, again, dependent on family history and dependent on personal preferences. But there is that option now, and I think at UCLH they are offering the ROCA test for women who might want to delay having the surgery for those reasons of family planning, for example. So UCLH are offering it. I think they are trying to roll it out more widely across the country. I don't know if you're offering it in Cambridge yet. Are you, Mark? We're not at Guy's yet.
No, not yet.
No. And I think one of the concerns about any screening, when you have a surgical option that we know definitely has a positive benefit on long-term outcomes, which we know that risk-reducing surgery for ovarian cancer does have a positive benefit, is that women might delay having the surgery for a screening tool which isn't going to have the same benefits in terms of long-term outcomes. So what we don't want is women delaying having surgery because they think that this is an equivalent option. So it is different to the breast side of things. Does that make sense? And when it's recommended, I think I'll probably cover this a little bit, but the risks actually below 50 with PALB2 are really quite low, probably about 1% risk below the age of 50. But there, we do take into account family history, and we take into account other factors such as menopausal symptoms, sort of an individualized risk assessment. And again, we can use CanRisk as a tool to help us with that assessment of when a nephrectomy might be recommended. But generally speaking, we would offer it from 50 onwards for the majority of women.
Thank you so much. A few pancreatic ones. I'm going to put them on. All of them, if Mike's still with us.
Yeah, I'm still here. Sorry, I lost my access. Somebody called in and it shut me off. I think we talked about the first one. The age thing is difficult. I think it's pretty difficult to screen below 40, but they are offering it to a few people because it's very unusual to get pancreas cancer, even with genetic risk below the age of 40. Should it be offered without family history? The answer to that is no, because all of the guidelines say no, because the risk is not considered sufficient. Can IPMN lesions stay dormant? Yes, they usually do stay dormant. They very rarely become cancers. So you can assume that that will likely stay a benign lesion for the rest of your life. Which about pancreas pumping is I
think we've covered that.
So that's outside of my world of interest, I'm afraid, as a plumber.
Thank you. Okay. Other cancers, always standing questions around prostate, linked to prostate, linked to multiple other cancers. Lots of carriers have got family history. Somebody in the family has got something else, and any non-cancer risks. So
just coming to the first one, I mean, I'd say that our current evidence is based on quite small data sets. So if you look at, if you think about BRCA1 and BRCA2, the current international data set is about 90,000 people, women and men. And, for PALB2, we're just in a couple of thousand, and we haven't really looked at those properly yet. So you can see that the amount of data you have really makes a difference. In the study that we did, we didn't see a link with PALB2 and prostate cancer, but it was based on very small numbers. There is a hint that if you have a man who's got a PALB2 mutation and gets prostate cancer, be it by chance, that prostate cancer is behaving in a more aggressive way than you'd expect. I think that still needs to be verified. I think I think the jury's a little bit out about the risk between PALB2 and prostate cancer. I think if there is a link, it's not going to be a very strong link. I don't think we can completely rule out a possible link or increased risk, but I don't think it's going to be a strong one.
And what about the other ones? Similar?
Yeah, I mean, not really any clear data to link it with other types of cancer, as Marc's already said. But you're right, Yulia, cancer can happen for lots of reasons in families and cluster in families, and so that's why in genetics we won't just look at the gene mutation but at the family history. And for example, if somebody still has a very strong family history for bowel cancer, we might still be recommending additional surveillance, but that's not because of the PALB2 mutation, it's because of the family history that we see. So I still think it's important that we are assessing the family history of cancer and looking at that and making sure that the recommendations that we're giving for surveillance are based on the evidence that we have for those different cancers. But I'm not aware of an increased risk for these types of cancer. PALB2, Marc, please correct me if I'm wrong.
Yeah, no.
And in terms of non-cancer, in
the EuroPac study, patients who've been followed up, where we're specifically looking at the pancreas, we've seen more non-pancreas cancers than we had pancreas cancer in those groups, which have included lots of things like breast cancer, like lung cancer, thyroid cancer, kidney cancers, prostate cancers. So, and that may be just because we're scanning people's abdomens and we're finding things at the bottom of their chests and so on. But how much of that's linked, I don't know. But about 40% of the patients in the EuroPac study do carry what's considered to be a high risk mutation of one form or other. So,
yeah, absolutely. And it's difficult, isn't it, to know how are they just cancers that you've happened to pick up that, through the ascertainment of it, or were they linked to the PALB2? But I think in terms of prospective data that we have following PALB2 carriers, there's not really clear high risks of those other types of cancer. And in terms of non-cancer risks, I'm interested if somebody's put a quote about diabetes. I wonder whether that's in relation to what you were talking about, Mike, and sort of those early markers of diabetes like HbA1c in relation to the pancreatic side, but I'm not sure
the
whether
assumption with diabetes is that people who get pancreas cancer or chronic pancreatitis or whatever causes damage in the pancreas. So if you have a cancer in the pancreas eroding your pancreas and damaging or blocking the pancreas, it destroys the tissues that make insulin, and therefore you present with your diabetes. It's not that diabetes increases your risk of pancreas cancer.
Yeah. And I wonder whether this question came from someone who had that link, because I'm not aware that PALB2 on its own is going to increase your risk of diabetes, or for example. So I think it's probably that kind of link that it came from, that question. Thanks, Yulia.
Okay, we're getting to hormones. Any risks of HRT with being carried for PALB2?
I think this really comes down to when you're taking the HRT. So if you're taking it because you've had your ovaries removed and you're of the age before the normal menopause, so under 51, then there isn't going to be any increased risk of taking HRT. If you're taking it after that age, then there is going to be a small increased risk, as there is for any woman who takes HRT after that age of breast cancer. Whether or not that risk is amplified in PALB2, we don't really know. But I think the general advice would be probably to avoid HRT after the normal age of the menopause if you've got a PALB2 gene alteration.
Can estrogen be taken safely after menopause?
Yeah, I think it's a really tricky one, isn't it? Because like Marc says, we don't have the data in the setting of PALB2. I mean, in women in the general population, taking HRT for a few, a short period of time, if we always have to balance quality of life and the positives of taking HRT as well. So I think it's important that women are counseled properly about the risks and benefits, and there's quite a lot of data to suggest that, not aside from PALB2, taking short-term HRT, less than 5 years, isn't going to hugely increase your risk of breast cancer. And there are lots of detrimental effects on your bone health and your heart health of menopause as well. So I think that debate about whether it's safe or not is really individualized risk assessment and benefit assessment as well. I don't think there's anything to say it's a contraindication, but you would be more cautious.
Hey, pregnancy question.
Yeah, I mean that's a hard question, and again because we don't really have data on this. So we know that if you have children, well, extrapolating from other genes like BRCA1, BRCA2, if you have lots of children younger and breastfeed, that is protective against breast cancer. But clearly, not everyone can do that. So there is some link between age when you're pregnant and risk of breast cancer, and if you're younger, then the risk is, it's protective essentially. But these are very small change. These aren't big risk. They don't have a big influence on risk. So in general, I think people shouldn't worry about it too much, and they just, I think they just carry on as normal, really. And because there's so many other risk factors that are probably more important than this, so I would tend to play this down somewhat.
A role of lifestyle changes and reducing cancer risk.
Yeah, I think really important always, aren't they? I mean, there's a lot of evidence that alcohol consumption increases your breast cancer risk. And, if we're talking about things like estrogen and HRT, actually the risks associated with a high BMI and drinking excess alcohol are probably higher than the risks associated with taking HRT for a short period of time. So again, it's about making sure everything is balanced in that conversation that you have with individuals, so that they're aware of the things that they can potentially do for themselves. And I think there's also an element of control as well that's important to bear in mind. What is it that you can do to help improve your own risk? And sometimes that can be very empowering for women to feel that, and men and women to feel that they can do something to improve things. Ultimately, though, it's not about beating yourself up about these things as well. So I think it's all relative, but certainly high BMI, excess alcohol, smoking, as Mike's mentioned, they're all things that we would encourage people to manage if they can.
Well, there's a couple of questions on insurance access. Can comment on those from the UK. Maybe perhaps a test.
I mean, in terms of insurance in the UK, I mean, women with a PALB2 mutation can access MRI screening through the Very High Risk Breast Screening Programme. So all women with a PALB2 mutation can or should be referred into the Very High Risk Breast Screening Programme to access annual MRIs from 25 years of age now. So I'm not sure about the aspect of it being not covered by insurance, because they should be able to access that through the NHS if they are eligible for NHS treatment.
And what about the test, different test?
Reliable direct-to-consumer test.
Yeah.
This is I suppose more for international situations, but I'm very cautious about direct-to-consumer tests. Marc, do chip in if you hopefully you agree, but there is some data to suggest that for some of the direct-to-consumer tests, there's a very high false positive rate in terms of the results, meaning I think one study showed a 40% false positive rate, meaning that the consumer's been told that they have a high-risk gene change, but when that testing is then confirmatory testing is arranged by us in genetics through an NHS lab, they don't carry a gene change. So I think be very cautious about some of the direct-to-consumer tests. And in terms of avoiding insurance disclosure, I mean, in the UK, if you're having a predictive test, there's a moratorium in place between UK insurance companies and the UK government to say that individuals do not have to disclose the results of predictive genetic testing for cancer risk gene mutations like PALB2. So predictive meaning the person themselves unaffected, but they're having a test to predict their future risk of developing cancer. You do not at the moment have to disclose that information to insurers if in the context of a PALB2 mutation. And that moratorium has been in place for many years and at the moment doesn't have an end date. There was some consultation around it recently, but as far as I'm aware, that's still the case.
Thank you. And this direct-to-consumer tests, are they all the companies who have them? Can you buy them from? Are they regulated?
That's a good question, and I'm not sure that necessarily all of them will be regulated. So these are where you can buy a test kit online. You do a swab of your own, you get sent it, and then you send it over to the laboratory wherever it's based. Some of the most common ones are things like 23andMe and those sorts of direct consumer tests. But there are more and more of them coming out onto the market. And I think it's important to have genetic testing through an accredited, validated lab that you have confidence in and with clinical support. Ultimately, these are important results that have far-reaching implications for people.
I think that stands true also for people doing direct-to-consumer tests with tumor markers and whole body MRI scans and so on as well. And so, because I see quite a lot of people who've done that and then understandably get into a state of anxiety about the fact that I've got pancreas cancer because my CA19-9 blood marker's up. And I think in 95% of those people, we don't find anything and end up following them up and doing a whole lot of tests because partly of the anxiety and partly because you've got an abnormal test to follow up. But as I said, most people, we find nothing.
Yeah.
So not recommended. Okay, and the last two questions are on children. Anything on prevention for children? Avoid passing it on.
Prevention for children. I mean, I suppose maybe the thing to talk about here for both those questions is just the option of PGT or pre-implantation genetic testing. So that's where couples undergo IVF treatment and then the embryos are screened to see if they carry the familial gene variant or not. And then couples can choose to have those embryos put back that don't carry the mutation. And for a gene like PALB2, where the risks for men and women are very different as well, sexing of the embryos can also be looked at. And there is sort of national guidelines around that. PALB2 does have a license with the Human Embryology and Fertilization Authority for PGT, and couples are eligible for PGT through the NHS, three cycles of PGT. As long as there are some stipulations. So, for example, a healthy BMI for the woman, they need to have been living together for a year, and no smoking for either of the couple. And there's an upper age limit of 39 for the woman, and that's because fertility declines quite quickly and the success rate of PGT becomes much lower beyond that age. So there are specific stipulations, but that's probably the main advance. But PGT has actually been around for many, many years and offered for genetic conditions for over 1 or 2 decades now.
Thank you for that. Well, that concludes then our advanced questions. I know people are eagerly waiting to ask live questions. I think at this stage we'll probably stop the recording and move to live.
Okay, that should have stopped now.
So let's see if we've got any questions in the chat.
I think it says you're now only recording.
No, sorry, I'm just going to do that
transcription
again.
stopped, yeah.
Sorry.
Okay, there were